right, well, let's move right along. And this is, this whole jam is really about caring for our own. Dr. Christine Yu Moutier will be the featured speaker on this, caring for our own, reducing risk and enhancing mental health. So we're just thrilled that she is on. She's the Chief Medical Officer for the American Foundation for Suicide Prevention. Next slide. Great, and I just want to note, we have 71 national organizations that joined the Crisis Jam, and the highest participation really occurred on the week of the launch of 988. We have 3,035 people that are part of this learning community, and so just thrilled for all that participation. If you aren't listed as a national organization and you are on, or you're from a country that is not listed, please let us know and contact Karen Jones. Great. And if for some reason you no longer have the Crisis Jam on your calendar, a lot of people noted that, there's just go on the website, you can click and download the Crisis Jam event. Karen Jones, you can also email Karen Jones to get it on there. This is the landing page for the learning community on Crisis Talk. You'll see the Zoom link. If you wanted to join right then, you can go there. There are highlights from previous jams, videos and materials, quotes, etc. So fantastic. As you can see, yeah, the latest highlights there. Great. Now, the 100th jam session, we have said over and over again, is going to be October 12th. It's changed. It's changed. So it's going to be October 19th. So September 28th and October 5th, there will not be Crisis Jam. So, and then October 12th will be a Crisis Jam, but the challenge will happen October 19th. Now, this challenge, this is a heads up, because in previous Crisis Jams, we have not said what the challenge is. This challenge is going to have a featured presenter, Dr. Don Berwick. He's the author of Patient-Centered and What That Should Mean, What Patient-Centered Should Mean, Confessions of an Extremist. So the cool part about this is pretty much what care really feels like, care that feels like care. It's more than just a lip lens. If you're a clinician, how do you really feel that, what care is? And so the next phase of the jam sessions will start at that 100th session with Dr. Don Berwick in that challenge. There'll be different elements from there. All right, great. And this is, we're going to go to some of our recent articles. This is one from Politico. Mental health policy continues to evolve. And there's a second article as well. And these are really about how there's been a 45% increase over the last year of people calling 988, and what a great volume there's been, and great performance with chat and text. So this is actually really reinforcing some of the data that SAMHSA has put out. And so it's thrilling that these are noting these successes. This is a McKinsey article on 988, 3 digits in the nationwide effort to help millions in crisis. This really, it includes and highlights an interview between Kana Enomoto, who at the time was acting director of SAMHSA, and at that time she and her daughter had a mental health crisis, and it really describes that crisis and how they got held up, even as Kana was in a leadership position, held up at the ER in this mental health crisis. So there are lots and lots of resources in this, and so we just wanted to note that. This quote is our coping reservoir. In 2010, Dr. Julian Holt Lundstadt's social relationships and mortality risk showed loneliness kills way before loneliness kills, and that was way before COVID. And so that is just so important. The importance of social connection is so key. So here's a quote. We wanted to know, and these were people that interviewed her, asking her questions. We wanted to know, does it vary by country? It does not. Does it vary by cause of death? Doesn't matter. Is it stronger for men versus women? Equally strong. This was a snapshot of real life, right? With implications for real life health outcomes. So this quote will be woven throughout this crisis jam. Okay, moving ahead. Great. And we are now going to move to the featured presentation of Dr. Christine Yu Moutier. She is the Chief Medical Officer of the American Foundation for Suicide Prevention, Caring for Our Own, Reducing Suicide Risk, and Enhancing Mental Health. When I asked Dr. Moutier what she most wanted me to highlight, I'm going to paraphrase and say that she is a human being. Humanity comes first. She has her own struggles, her own family struggles. She's from the inside of it as well as being a clinician. So she can speak from the inside and from the clinician perspective. Dr. Moutier, thank you so much for being here. Please go ahead.
Thank you so much, Megan and David and Karen and the whole Crisis Jam team. This is really exciting to be here with you all because we are all in this together, but it's kind of a really special opportunity to get to speak with you directly about how we can think about our own well-being and mental health and think about the care that we can provide for each other as colleagues, So yes, let's go ahead and move on, David. Thank you. So in the next 15 minutes, I'm basically going to cover two buckets of topics and really look forward to the roundtable discussion with Janelle Cubbage and Jesse Gold that will follow this. So we'll first talk about distress and stigma and various aspects of our own mental health and well-being. And then really the last part I'll focus on are possible solutions. And when I think of solutions, I'm really talking about at the organizational or culture institutional level, as well as what we can do as individuals. This should never be on any one individual, to carry these responsibilities on their own. So just thinking about the moment that we're in, and this is a slide that Arthur Evans had put together and graciously allowed me to use that really just I thought was so striking because the pandemic's impact on the population is so multifaceted. And so if you just look at, kind of a smattering of these highlights about not just the health impact itself of COVID, but the loss experiences, the way that distress was amplified, the economic strain and unemployment experiences that many people had, the fact that more people in 1 year than ever before died by drug overdose in 2021, other aspects of just unrest in the population. I mean, how ironic is it that during the period of lockdown, even when there were barely cars on the road, that motor vehicle accident fatality was up during that period of time. So the reason to, to just sort of give us all of this, the sort of doom and gloom aspects of the pandemic's impact all at once here is to say that for each of us, we have different experiences with this because it touches us as individuals in different ways. And I'm also thinking about the fact that in your role, it's kind of a double whammy in the sense that you may have directly experienced some of this for yourself, for your family, for your community, but then also in your professional role, supporting others when all of this is going on. There is that element of almost, you can call it vicarious trauma of needing to step up for this level of impact during these last couple of years. Next slide. So my own journey is that when I was in medical school, I experienced my own serious, life-threatening mental health condition, was suicidal during that period of time, thought I was unfit and didn't belong in the field of medicine. And fortunately for me, got help for the first time. And so I'm, like many of you, I'm a huge proponent of not only therapy and psychiatric treatment for ourselves when we need it, but the whole host of other self-care strategies and the ways that we can lean on each other. And of course, that's what this overall talk is going to be about. What followed that for me, though, when I came back to med school training, became a faculty member at UCSD. By the time I was dean for medical education and student affairs in the School of Medicine at UCSD, the university health sciences community had experienced the suicide deaths of 13 different faculty physicians across all different specialties. And so by then, because of that lived experience of mine, being super passionate about doing something about the disconnect between an experience of being human and struggling in a culture that does, at the time, really didn't permit that to even be mentioned, let alone addressed very proactively, I was in the position to help co-develop the start of a program that's still going strong to this day, a suicide prevention program for the physicians, trainees, and now it's actually for the whole staff, including nursing staff and any health worker, and actually even like admin staff at the University of California, San Diego Health System. And so that was an in the trenches experience for me. Even though I was a psychiatrist and a dean, that didn't mean that I understood the science about what drives up risk and what constitutes effective suicide prevention. Next slide. Now, I mean, I'm not going to do this justice because mental health distress amongst our own health community, like health professional community, is a vast topic and is not new during the pandemic. Issues of depression, anxiety, substance use, suicidal ideation, and suicide mortality have all been measured to varying degrees of accuracy across multiple healthcare disciplines. Some of these facts I have on the slide focus on physicians and nurses. There is a little more data for different disciplines, but the take-home point here is that we are all human. We all have our own mental health to manage. And that's a very dynamic situation related to our own genetics, our own early upbringing, experiences of trauma, very human experiences, along with internal biological and internal factors that are interacting with the culture and the environment and our stressful life circumstances. And our identity is meaningful in all of this in terms of our well-being and mental health outcomes, meaning many of us gravitate towards these healthcare professions because we identify with helping others. We identify ourselves as a helper and a caregiver. So sometimes that presents an extra barrier in realizing that I'm fully human too. I need to also be the recipient of leaning on others and seeking professional mental health treatment when I need it. The other issue of identity is that we have intersecting identities, of course, depending on our race, ethnicity, gender, our family of origin, many cultural aspects to our identity. And all of those can sync up with our experience that ultimately relates to our own well-being as well. Next slide. The barriers to help seeking amongst healthcare professionals have been surveyed and studied a lot, and including during the pandemic. And what we know are that there are significant concerns around the impact of, still, even in this day and age, stigma, keeping us in the shadows and silenced when we are struggling. Remember, there's also a human experience that we have, which I'm going to get to. We also fear, sometimes very legitimately, fear negative repercussions on our career path or our reputation if we, quote unquote, come out as having our own mental health struggles. And of course, cost and time are other issues. So there are some studies that speak to this a little bit in a bit more granular way. There's a study that looked at physician suicide decedents compared to general population decedents. of suicide, and found that the physicians who died by suicide were as likely to be suffering from a mental health condition, but less likely to be in formal treatment. So, how ironic and paradoxical is that? That study also found that physicians are tending to self-prescribe or obtain psychotropic medication for kind of short-term reasons, either self-prescribing or informally from a colleague, instead of affording ourselves the full opportunity for professional evaluation and help. And so sometimes that short-term thinking can actually do harm to us because we're focused on our sleep problem or our panic attacks, but we're not seeing the full picture because we're living inside ourselves. Even as health professionals, we are not objective about our own mental health. Next slide. This is really to point out that we are human beings. So in addition to all the cultural aspects and professional issues in the environment that might make it extra hard for us to seek help, we are human at the end of the day. And that means that when we're struggling, we have a reflexive experience that I would say is both cultural, but it's also very primitive, that we go into a state of barrier up and feeling ashamed and vulnerable, not wanting to, to be open about our own experiences. And that's a huge barrier. And it has implications that we need to overcome for our colleagues. We can assume that we need to make an extra safe space when we reach out to a colleague who might be struggling. So go ahead and just flip through the next two clicks here. So you see in this study that medical students who were surveyed about these various attitudes, telling a counselor I'm depressed would be risky. And notice that the ones who likely were depressed, meeting some criteria by PHQ-9, the ones who were depressed were much more likely to feel that it's risky to tell a counselor that they're depressed. And the statement, if I were depressed, I would seek treatment. Again, ironically, the non-depressed students, the majority said, yes, I would seek treatment. The ones who were depressed were far less likely, less than half of them. And again, these are students in the same cohort, exposed to the same curricula, but that's the human element in all of this. Next slide. Okay, so solutions and best practice, and I'm gonna wrap this up very quickly here so we have time for our roundtable discussion. First of all, coming out and talking to trusted peers, family members, colleagues, therapists can help. It helps by setting a tone that these are normal experiences and that help seeking is a sign of strength. And these are some just examples on social media and in the medical community and others, nursing community. There are lots of official, publications publishing these stories of lived experience, which is really powerful. Next slide. We also see that happening, of course, in the general culture with lots of celebrities and athletes coming out as well about their own lived experiences, which is generally a very, very helpful thing. So on an individual level, I'm trained as a psychiatrist, which means we train in more like disease states and psychopathology and treatment. But then I became a dean where you have to think much more holistically because not all of your colleagues and trainees have mental health conditions, and yet everybody's experiencing dynamic changes in their mental health. And so I came up with this sort of very holistic model. It's a conceptual model that looks at our resilience and coping. Why on one day do I respond in a self-compassionate, mature, long view to a frustration that comes up, but on a different day, I'm the same person, but I respond with such a different outburst of, feeling of frustration, agitation, losing my temper. And so again, all of this conceptual model grew out of that. And you can go ahead and just click through some of these things. So let's just say we have this substance that we're drawing from day to day. I will call it our coping reservoir, and experiences of humiliation, shame, rejection, sleep deprivation, loss. If we've experienced past trauma and now it's being reactivated, all of those things can drain our reservoir in an extra way, because I would just say that everyday life does drain us and we have to keep this up. And go ahead and click through the things that can fill up our reservoir, things like sleep and exercise, affirmation, debriefing and processing conflict, connecting with one another, and availing ourselves of therapy or treatment when we need it. Next, click. And so really the question is, this is individual for each of us. We can customize this approach and practice this in our lives by asking ourselves the question, what drains my reservoir and what fills it up most potently? And you can think of those nourishers as your psychological PPE, so to speak. Next slide. Now, if you notice that a colleague is struggling, what I would say is, first of all, trust your gut, because we have all kinds of ways that we talk ourselves out of the need to approach a colleague. But that radar goes off inside you that says something's just different about the way that they're behaving, their tone of voice, they sound more overwhelmed. And so there is a way for us to approach each other that we can talk more about that is not being each other's doctor or therapist or clinician. We are colleagues to each other. We get to care for each other. We get to invite them to share what they're experiencing so we can simply listen and support them, again, as a colleague. There's really no further responsibility than that. There's a lot of maybe confusion out there about what we need to do. But remember, you're not acting as their administrator, their boss, their training director. You're simply a colleague, you're a peer, and more in a friend role. So wrapping up, we all have a role to play. Depending on your the professional hat that you wear, you may have some extra ways that you can support suicide prevention and optimizing mental health for our own community of health professionals by making sure that mental health is always addressed as a part of health, meaning we should not, if you have anything to do with the clinical privileging practices of your hospital or crisis system, or have an influence on your state medical board, make sure that questions about mental health are not part of the licensing and relicensing or the hospital privileging forms, or if they are, that they are focused around health issues broadly that impact safe practice and competence in the current day. That's the more legal way by ADA standards to ask the question, but really it's not proven effective to even do that. And as individuals, we can, of course, prioritize our own mental health and really look out for one another. Next slide. These are just some of my favorite resources for us as health professionals, especially that middle section there. Those are all specific clinician support resources that we can access. Some of them linked to free therapy or groups, substance use, recovery groups, et cetera, for health professionals. Some even find therapy for low cost or for free for health workers. And just a tiny little plug, I did write a book on suicide prevention that covers this for ourselves as well. Next slide. And I think we're done at this point, and I'll turn it back to Megan.
Dr. Moutier, amazing presentation. Every time I wrote a note, you were answering the question in the next slide. You know, how do you fill your reservoir? You know, how do you approach a colleague? I love that image of what it looks like on the outside. The sock looks fine, and then that sock, it's like a rock in your shoe where it just feels uncomfortable. That's fantastic. I did want to note a few comments in the chat where some, including David Covington and some others, noted that their mental health was questioned when getting licensed or relicensed, and that is interesting. And one noted, context leads one to believe that seeking treatment is a professional deficit that the board needs to review and consider seriously. So just some agreement with you on that, Dr. Moutier, that shouldn't be part of the relicensing and licensing. I did want to turn this over to the roundtable to Janelle Kubich, who's a psychotherapist, suicidologist, and Bloomberg Fellow alumni. Janelle, please, what are your thoughts and reflections?
Thank you, Christine. That was a great presentation, and something that I'm reflecting on, and a question that I'm left with is, why are we so punitive to people who are seeking help and taking care of themselves, especially when we are the ones ourselves providing such care to other people? It's counterintuitive, and the call is coming from inside the house. We have to address this within ourselves, our own internalized stigma. And I in some ways, am just lost for words to know that there are still licensing boards that are asking about mental health questions on licensing applications, and to me can send so many other messages. Do you believe in the treatments that we provide to people, that they work, that we can help people live productive lives? I do, and that doesn't make me any less of a therapist or healthcare provider, and that's true for anyone. So I really hope that we can begin to turn the tide on that. The other thing that I'm left with and really reflecting on is connection. So how many times throughout our day, in our various settings and in our roles, do we have opportunities for authentic connection? So I think about back in the days when we were in the office, some of you may be in the office now, passing by colleagues, saying, good morning, how are you? And it was a very quick exchange in passing. So I want you to think about the last time that you asked a colleague how they're doing, and really reflect and challenge yourself to examine whether or not you really wanted to know how they were doing. And I want you to think back to the last time someone asked you how you were doing and how you responded. Were you honest? I think sometimes we get caught up in these niceties that really lead to these superficial connections, or connections that don't truly foster engagement, connection, and ability to be vulnerable with one another. And Christine also mentioned listening to your gut. And I think that's so important. That gut feeling can key us into things that we are picking up on if we're worried about someone, and you should trust it and follow it. If you trust it and follow it and it turns out that they're fine, you just invited an opportunity for them to come talk to you at a later date, and you opened up the door to be able to have these conversations like we should be able to. We shouldn't have to keep our mental health or our treatment for mental health in hiding. I also really appreciate that Christine highlighted that burnout cannot lie solely on the individual. Burnout is very much a structural and systemic issue. So obviously there are things that we can do, like knowing what fills up our reservoir, what depletes our reservoir. However, we have to be living within systems and communities that enable us to do that. So if you're an administrator or you're in a decision-making capacity, if you're a supervisor, are you giving people time off to go to appointments? That's one very simple thing that we can do. If we think about availability for healthcare providers, some might offer nighttime appointments, but most may be operating during normal business hours. So how are we making accessing treatment accessible for our folks? Are we being mindful of schedules and hours worked so that folks can have good sleep hygiene? Are we being mindful of caseloads and being able to balance that with other responsibilities for people? And are we checking in with them when these large national happenings are going on that are impacting us, and we're having to cope with them as we're trying to support our clients and patients through them as well? So
Janelle, that's awesome. I'm so sorry. I want to give Dr. Gold a chance to also reflect. Your comments are so amazing. Dr. Gold, what are your thoughts on what Janella said, as well as Christine?
Sure. I didn't want to cut her off because I was listening.
I know.
No, I appreciate it though.
Fabulous. Right on.
Yeah, so, I think from my perspective, so I'm also a psychiatrist, but I treat healthcare workers and their family and their college age kids primarily. So if that gives context from where I'm coming from, I'm also a person who struggled in medical training and struggled as a pre-med and wasn't even sure I wanted to be a doctor. And along the way, realized how messed up the system we educate is. And it's the same kind of across specialties. And I've only learned more and more from hearing from other people. I think that a lot of what we're talking about is that there are these two forces at play in what we're dealing with, right? Which is like there are systemic reasons we don't get help and there are personal cultural reasons we don't get help. And the systemic ones are things that people in administration like me need to be working on, which is like, how do you make appointments accessible? How do you have people afford it? Because most of the people we're talking about are the doctors and nurses because we have the data, but what about the people who clean the hospital? What about the people who don't have full-time positions and get benefits? So how do you make that accessible for people? And at the same time, how do we help each other feel okay getting help? And that's the cultural part. And a lot of that comes from vulnerability and feeling comfortable actually talking about these experiences out loud, which Christine talked about herself. I've talked about myself. I think it is seen as brave to talk about yourself in any way. And I think it should be seen as normal. I often talk to people about how they don't have to tell their entire mental health history to make people know that they're a supportive leader or supportive supervisor. So are you tired? Is medicine hard? Is a training experience something that you shouldn't be dealing with, but that's how it is? And so you are, like these things that we don't say out loud enough that we need to say so that what we're experiencing feels normal. In that context, we'll know that we can then go to people for support and feel supported or know that they know how to get us to help. I think those other barriers, like things like licensing, is across the board a problem. It's something that I've studied. It violates the Americans with Disabilities Act, but unfortunately, the people who control licensing are state licensing boards instead of a national system. So it's a state-by-state advocacy thing. It's something the Lorna Breen Foundation is working on. It's something there are some other like grassroots support kind of working on it. And I think it's important that we look at all licensing and credentialing. So even if we change licensing applications, that doesn't mean we changed credentialing. So you also might need to be asked the same questions at work. And I agree with the people who said the context of the question matters too. So even if you're just asking about impairment from mental health, which would mean that it was like a recent thing and actually affecting your ability to provide care, which would be legal, if it's asked in the same questions as criminality or pedophilia, then it really is sending a different message. So we do need to look at context and the kinds of questions that we're asking as much as the violations within them. So these are all really big issues, but I think it really comes down to the fact that we need to see ourselves as human and the work that we do as hard and deserving of help, which we don't always do. I think that all through the pandemic, I was like, I'm seeing frontline workers. I'm not a frontline worker, despite really listening to hard stories and having more patients, more crises, more need, and a really significant inability to help people sometimes, which is like a moral injury thing. And we don't tend to realize we need help because in that context, we are taught to take care of other people first. And we're just mental health providers or we're just crisis line operators, right? And at the same respect, we really need to say like, our jobs are hard and we're allowed to suffer or struggle because of them. And because of that, we're allowed to ask for help and we need to validate that and talk about that more out loud and notice that like we're human. And if you listen to this sort of stuff every day, it is going to affect you. I think that's really important.
These are all just amazing points. And if you look at the chat, there is a lot of people are getting very moved by what's being said. We all want to help. We all want to give. And then, how can we make it an us versus them type of dynamic if we're also not able to talk about our experiences and get help for those. So thank you so much, Dr. Moutier and Dr. Gold and Janelle. Fantastic presentation, so important. Thank you. We're now going to move to the trivia hot seat. I want to note that anybody in the hot seat can get a jam session t-shirt. You can pick your English or Spanish, a quote, a logo, and you can order these. So I know Karen will be putting the link in the chat on how you can order your own shirt. Apparently they're going like hotcakes, so go for it. And I believe Al Guida is our trivia hot seat person this week. Is that right? Al, are you on?
Yes, I am
Yay.
a trivia hot seat participant. I'm so excited.
Al, you're always in the hot seat. You know what I mean? You're just to be very on. So Al is the principal for Guide Consulting Services. And Al, this is the question. Social isolation and loneliness are significant predictors of long-term health outcomes. But how do they compare with other behaviors like smoking, inactivity, and excessive drinking? So which of the following has the second greatest impact on health outcomes and longevity? Now, the audience will answer, and you can go and see what the audience thinks and go with that, or you can call a friend. What do you think?
So well, you know, now I used to be a heavy smoker, as a matter of fact, and certainly that had an impact on my health. But my guess is A. That the
All right.
board says A, social disconnection.
Isn't that interesting? And that looks like what the audience went for as well. Is that your final answer?
Yes, it is my final answer.
Okay, great. If you could reveal the answers, please. Okay, so normally we don't do this in the trivia hot seat. This time there was a tie in the answers. It could have been A or B, social disconnection and smoking 15 cigarettes daily. Now, the important part here is there's a science alert, you know, hashtag social isolation is as bad for your health as smoking. So, and that doesn't simply mean psychiatric challenges, by the way, but heart attack, stroke, diabetes, risk of dementia, and more. So thank you, Al. You nailed it.
But see, I referenced smoking in addition to social disconnection. So
How cool
I
is that?
got both of them, baby.
You merged it. Yay, you're getting some applause. Very good. Al, thank you very much.
My pleasure.
Right.
Thank you.
We're going to move to the SAMHSA update, and I'm going to move this to Dr. John Palmieri.
Thanks, Megan. That happened so fast. Good to see you. Good to see everyone. So I'm just going to mention a couple of things quickly, and then I'm going to hand it off to our communications lead, Kate Galatis, who's just going to walk through a couple of updates for everyone on the call. But one thing I wanted to flag is, and I think there was some reference to this in the chat, there was a press release that went out last Friday from HHS speaking to the performance data of the Lifeline Network for the month of August. I think we've talked before about wanting to promote increased transparency in metrics and how the network is performing from an operational standpoint. So I will throw in the chat the press release that does include links to performance data and just kind of some high-level remarks there. Volume has gone up significantly. Many more people being supported through the Lifeline, which is obviously a good thing. Significant improvements in response rates, particularly for chat and text, and decreases in average speed to answer, which are all outcomes that are positive, and we're definitely moving in a positive direction. There's of course more work to be done, but very happy about the direction that we're going in, as well as being very happy about the increased local response, and we're seeing a significant capacity building within states and territories to provide 988 response, and that's also moving in a very positive direction. So appreciate the partnership there. And then the only other thing I'll flag as part of that press release is a new grant opportunity to support tribal nations and tribal organizations around 988 response. And so there's a link to that grant opportunity in the press release. And we are working to set up a pre-application webinar to support applicants for that grant opportunity. So there'll be more to come on that as well. And now I'm just going to hand it off to Kate to provide a quick update on some of the great work that they've been doing with the toolkit and materials for partner dissemination.
Thanks so much, John. Thanks, everyone. It's great to be back with you guys. I'm going to drop in the chat here.
Hey, you're on mute.
Okay, sorry. We are just releasing some new social media shareables. So I'm dropping the direct link to those in the chat. These are things that we hope folks will lift up and share widely. Those will be kind of bundled together and pushed out later today in what we're calling a social media toolkit. So that will be an extra way that we're trying to really get the word out there that these resources have been added to our toolkit. The print materials, and yes, please use them widely on all the chat on all social media, please use them. So in addition to the tools and resources we have available online in the partner toolkit, like the social media shareables, we also are adding to our inventory of materials that people can order in the SAMHSA store. So know that we know there are limited items there now because they're going like hotcakes, but we are adding more wallet cards and more magnets, some of which I'm being told will arrive as early as next week. And then we are also adding stickers, 988 stickers to the items that you can order from the SAMHSA store. So all of those materials, while we know it's best and easiest to order them from the SAMHSA store, we also have all the print ready files in our partner toolkit for everything that you could order in the store. And that is there because while we are facing some of these inventory issues, we know that some of you may want to just kind of print some of your own materials. And so those files are there. I want to also talk about one other item, and that is we would really encourage folks when you're promoting 988 to please use kind of our standard, what we call our standard call to action. And that is to call or text 988 or chat 988lifeline.org. The important point here is that what we're really trying to make sure people understand is there are multiple ways to access the lifeline. It's really important that folks know that they can do any of the above. They can call 988, chat 988, chat 988 at the 988lifeline.org or text 988. And as John mentioned and as mentioned earlier in the news coverage, since the lifeline, the volume's going up and the network itself is responding so well, we really want to make sure that folks truly understand all the different ways they can access it. It's really important. So you will see that what I'm calling that call to action. You will see that on all of our materials in our toolkit, but specifically if you're working with the news media, you can point them to what are called media end cards. And these are also in our toolkit, but these are the things that the news media and program directors and film and content developers use to plug onto the beginning of an article or the end of an article or a newscast. And we want to make sure that those are really referencing this full array of ways that people can connect to the lifeline. So thanks, everybody.
Back to you, Megan. I think that's it for us.
Great. And I'm getting messages that people are asked to unmute. Just mute yourself. I think it was intended to be, just the presenters to make sure they were unmuted. We're going to move to NASHBID to Aaron Walker, who is the policy lead at NASHBID. Go for it, AJ.
Thanks, Megan. I have to say you're doing a great job today. I just wanted to make that note. And this has been a great crisis jam. I'm glad to be here. If you look into the chat, I put in a link to this document that's coming up on the next slide. This is some resources that we've been sharing with our members lately. It's from the Center of Excellence for Public Health Information. This is a SAMHSA funded project that develops and disseminates resources, training, and TA, basically to improve understanding and application of the federal privacy laws and regulations. And this includes FERPA, HIPAA, and 42 CFR Part 2. You'll see here on the page that they have hyperlinks to a suite of e-learning modules, as well as hyperlinks to a suite of telehealth resources. So definitely feel free to go through these, review these, and share these with your constituents and your networks far and wide. And I will turn it back over to you, Megan.
Great, thank you. And I did want to thank SAMHSA for the excellent pieces shared there, Kate. You're just doing a fabulous job. And AJ, thank you for all of your work as well. Let's move to the data corner. We have Madhuri Jha, who is the director of the Kennedy Satcher Center for Mental Health Equity at Morehouse School of Medicine. Madhuri, take it over.
Thank you for having me. And I do want to preface this by saying that I will be rejoining the Crisis Jam to do a more comprehensive presentation on some of the work we're doing. So we wanted this to just be an intro to the highlights. Just a little bit about us. We were founded by Patrick J. Kennedy and Dr. David Satcher, 16th Surgeon General of the US. And we really promote the idea that mental health equity is integral to overall health equity, which is super salient now when we talk about 988 and certain communities that are affected by a mental health crisis. Next slide. So one of the things that we want to highlight for today's data corner is to just plant in your minds what it means to power equitable data in 988. And so one of the things that we tackle very directly is to understand that there are barriers to understanding the intersection of equity and behavioral health in the way that we as systems collect data. And what we ask for is that we use 988 to account for the collection and disaggregation of robust data and evaluation standards to capture equitable outcomes. What does that mean? We want to make sure that we're reaching the populations in need, and we want to understand who they really are. Next slide. So I'll get into this when we present in our extended conversation it will be in October, but we did some work to investigate from a research perspective exactly who has been historically invisible in our psychiatric emergency system. And you'll see here that it's no surprise that a lot of these communities are overall struggling to get full access to care in public health in general. But to highlight, it's people who identify as LGBTQIA+, people who live in rural communities, people who live with disabilities, both invisible and visible, people experiencing homelessness or housing instability, survivors of trauma, Black, Indigenous, and people of color, immigrants, refugees, and non-English speaking people, older adults, formerly incarcerated or justice-involved populations, and people experiencing neurodiversity. A very, very comprehensive list, of course, but it's important that we, from the equity side, try to do our best to promote the priority of their needs and the work that we do from a data perspective. Next slide. So we were able to develop a series of recommendations on how we can see equity can be embedded into 988. I'm going to talk in detail about those in October. I just put in chat the actual policy brief that we released in June ahead of the launch that we hope becomes a helpful tool so that states and local implementers can get a better sense of how to meet the need. But one of the things that I wanted to highlight from a data perspective is how we intend to be able to support the 988 crisis response system from an equity lens. We believe it's a critical moment to ensure that historic failures are rectified and done so in a culturally attuned and client-empowered manner. And if you go through the policy brief that was shared, you'll see that there's certain ways that we think that that would be especially meaningful. But in the interest of time today, I'll just talk about what we intend to do over the next year or two at a baseline and hope to expand upon, hopefully with this community's help. There is publicly available information at a state level that SAMHSA is leaning into states to be able to help us look at. And we've identified that those kind of can be captured into 3 different domains: the overall state implementation plan of 988, the development of an advisory board or an advisory council that can assist with 988, and of course, a marketing strategy to get the message out about making 988 accessible to all. And so what we want to do is to be able to see if those plans, those boards, and those marketing strategies have specific outreach focused on the groups that we identified being the most in need. And currently that's being done through just simple mesh term searches, seeing if those names appear, those words appear as their mention of them or their strategies. But we want to be able to uplift best practices so that other parts of the country can learn from each other and create a learning exchange network that hopefully becomes meaningful. But I do hope you'll tune in October so that you can learn more in detail about the work that we're doing and figure out how you can help us. So I'll stop there, but please take a look at the brief and be free to reach out to us if you have any questions for the future.
Wonderful. Madhuri, that was fabulous. Matthew, did you want to say something?
Yeah, I was just going to add briefly, Madhuri, thank you. That was awesome and really looking forward to your featured presentation. As always, we share a couple data corner bites each month. And on this list of publications, I want to share just 1 minute on this first article, which I think has some really important findings for this field. So the study by D et al., a community response approach to mental health and substance abuse crises reduced crime. This was published in Science Advances, which is a major journal. And they showed that in Denver, where a community response pilot had been implemented, that in terms of crime statistics, the program reduced reports of targeted, less serious crimes like trespassing and public disorder by 34%. That's an amazing reduction in that kind of crime reporting by having a community response that's able to respond to people who are in crisis as an alternative to law enforcement response. Importantly, there was no detectable effect on more serious crimes. So the more serious crimes were still being reported equally. And then also importantly, even when the program was not active, so it wasn't active 24/7, there were spillover effects that showed that the reports of these less serious crimes even reduced during off hours. So some really compelling findings from that study to demonstrate the benefits of having these alternatives to law enforcement responding to people who are in crisis. The second article, I'll also add the link to that has some important sort of guidance on how to approach research safety protocols in this space. Thanks so much.
Madhuri and Matthew, thank you so much. This data corner we do periodically on the Crisis Jam, and it's just invaluable. We're really excited also about the future presentation. We're now going to go to the live lens and vision of 988, and just delighted to have DeQuincy Meffron-Lizine on, who is just, when I read about DeQuincy, he just warms my heart. He's a survivor and also started the very first student-led suicide prevention group in college, a college level, and just very moved. So DeQuincy, please tell us about what you think it will take after this first mile to then reach the promise of 988.
Okay, first, I apologize for any lag because I'm on a satellite connection, so there's probably a delay. But I kind of was thinking about the Uber model, and I don't want to particularly promote Uber over any particular other service, but it's the one that I have the most familiarity with. I've kind of watched it develop over time. And so that now it's at the place where in sometimes you get to an airport and they will tell you exactly where you need to go to get your ride service. You need to go over here, you need to cross over to some other location, and here's where you'll find your ride. And so that's kind of one level that's up from just only being able to catch a cab or only being able to get a super shuttle or something like that. But the ones that I've really enjoyed is when the app asks you, would you like to share your location with the person? Here is a map that shows you where your ride is. Here is the person who's coming to pick you up. Here's what their car looks like. And then even the Uber comfort aspect, which is like, would you like to have it be quiet? Would you like music or not? What temperature would you prefer? And so it gives lots of options. I think that if we had the ideal crisis response, it would provide people with options. It would provide people with information about who is coming to interact with them. And if we're going to have a crisis mobile team, they know who is going to show up, they know what to look for, and it provides them with a degree of empowerment and choice, which is automatically going to kind of counteract the sense of powerlessness and helplessness that somebody is going to have when they are in crisis. So showing up with peer providers, perhaps with animal-assisted crisis response, showing up with a group of professionals and giving the person as many options as possible. I think that is going to really improve the type of crisis receiving that they have. And then trying to come with the approach of how do we get somebody to stay at home and feel good? How do we provide places that they can go to so that somebody who calls is not going to feel like, okay, you're going to call the police or somebody on me and they're going to come and take me somewhere and do an intervention on me, but instead providing something that's more trauma informed and more options oriented, more empowering, that says, here are the different choices that you have. We are coming to you with resources, and we want to make those as available to you and as facilitated for you as possible so that we can help you to get the services and the care that you desire as quickly as possible to help you to resolve your crisis.
Quincy, thank you so much. I want to note some messages in the chat. David Covington says, Dr. Mefren Lazine and Heidi Bryan were among the first in the US to publicly speak and write about their own lived experience of suicide attempts, just breakthrough leaders. And I love your Uber analogy, your metaphor, the air conditioning. It's very person-centered, very honoring, very engaging. And I think that's right on. So thank you so very much for your perspective on that. Do you want to talk about the Crisis Talk article? This article was written this week by Christy Malik and Neely Ezekiel with NASHBID. And thank you so very much for your work on this. And it's how a state planning grant helped Missouri expand its crisis system. Is Stacy Williams on? Okay, Stacy may not be on, but we do encourage, oh, there you are, Stacy. If you can take just 30 seconds, tell us a little bit about your.
Yeah, thanks for having me. Yeah, please check out the article. It really just talks pretty candidly about how Missouri used the planning grant to help structure our crisis system, also to bring in consultants to do a needs assessment. And I'll just say we really, we started planning for 90-day prior to the planning grant, but that really provided like a structure for us. And we also talk about in this article some things that we need to improve on and we're still working on, because as we all know, it's a work in progress. So definitely, I would say check it out. And yeah, thanks for letting me give a shout out.
Great. Stacy, that's fantastic. And those planning grants have been so good for so many states. And wanted to also just note, Moving America's Soul on Suicide, the episode 6 is just about to be released, and Craig Miller is the focus on that. So delighted. That's a fantastic series. So actually it's just released. So Karen put that in the chat. And the coming September 21st is the featured presentation, Self-Assessment for Modification of Anti-Racism Tool, SMART tool, and Dr. Rachel Talley will be that featured presenter. Rachel, are you on by any chance? Okay, so just be there September 21st. It'll be fantastic. There's some other presentations as well. Just a reminder, there will not be a crisis jam for after September 21st for 2 weeks, September 28th and October 5th. There will not. There will be one October 12th, and the challenge for the 100th episode starts October 19th. That will be a fantastic next phase for the Crisis Jam, and we invite you and all of your friends, everybody you know, to join that Crisis Jam and the others after that. So thank you, everybody. Have a wonderful, wonderful afternoon. Thank you to all the presenters and all the perspectives. This has been a great jam. Have a great afternoon.